Hello, this is Michael Hogue. Welcome once again to Addressing the COVID-19 Crisis, an open forum webinar series for pharmacists. We're so glad that you're with us. As I mentioned, I'm Michael Hogue. I'm the president of the American Pharmacists Association and dean and professor at Loma Linda University in Southern California. We are so grateful that you've joined us today for, I think, what you'll find is a very exciting and interesting webinar today. Discussing epidemiology of COVID-19. As we have gone now about 15 or 16 weeks of these webinars, we've covered an awful lot of topics and realized that as we are seeing a surge happen currently across the country in COVID-19, that it would be a very good time for us to cover the epidemiology and what's going on and why pharmacists really need to understand the truth about the epidemiology and the numbers. And so we're pretty excited to be able to have this conversation with you today. Now, we have a very special guest speaker who's going to be sharing wisdom with us on this topic. Dr. Vibhuti Arya is Associate Clinical Professor at St. John's University College of Pharmacy and the Clinical Advisor to the New York City Department of Health and Mental Hygiene. I think it's very important for you to know that, Vibhuti has been right in the middle of what has been the worst part of this COVID outbreak over the early days of the COVID crisis. As all of you know, New York City has experienced tremendous morbidity and mortality associated with COVID-19, and Vibhuti, as a faculty member, has been engaged directly with the Department of Health on this. So we're going to get tremendous wisdom and insights from her personal experiences, but also from her knowledge related to the epidemiology of COVID. Now, we're also this week going to have, during our Q&A session, the opportunity to hear from Dr. Dan Slott, and Dan is the Vice President for Professional Education at APhA. He's able to join us every week, and Dan, we appreciate you doing that. Dan has a 10-year history of working at the NIH as an oncology specialist and working with immunology as well. And so you also may know Dan as the host of COVID 15 on 19, an APhA CE series. We'll talk more about that later. And also Dr. Lisa Bernstein is with us today. She's the Senior Vice President of Pharmacy Practice and Government Affairs at APhA. And Lisa joined APhA's staff after a 30-year career with the Food and Drug Administration. So today you're going to have the opportunity to ask questions, not just about our topic of epidemiology. That's an important thing, and you're certainly welcome to ask the questions that you want to about that, but you'll be able to ask questions about anything related to COVID-19, whether it be drug therapies and treatments, or perhaps you have a legislative or regulatory question that you'd like to ask. Now, I just want to orient you to the webinar panel, the GoToWebinar control panel, which probably appears on the right side of your screen. Should have a chat button there or a questions tab. As you think of questions, we'd like to encourage you to go ahead and enter those questions, type them into the box as you're thinking of them. If our speakers don't address those topics or those questions during the course of the presentation, then we'll have an opportunity to ask those questions when we get to the open forum question section. Now, there's two ways we can do that. One is that we would prefer to unmute your line if it's possible and let you ask your question directly of the speakers. It's more interactive, and we think that provides for more interesting webinar. But if for some reason your audio is not working, you can just say no audio, and I'll ask your question for you so that your question gets out there and we're able to hear the answers to your questions. If you are on a landline or cell phone and you have not yet entered your audio pin, you need to do so now, because we will not be able to unmute your line if you've not entered an audio pin. If you're using the web or computer-based audio, it's no problem. It's just simply a matter of unmuting your line. The other thing to point out is there is a handouts tab, and the handouts, including the slides that Dr. Arya has provided for us today, are available for download, and you can keep those on your computer and refer back to them later. We'll also make today's webinar available because we're recording it, and so it will be available long-term on pharmacists.com. Usually we have those posted within a day or so after the webinar ends, and you can have your friends visit pharmacist.com and listen to the webinar there through our YouTube channel or through the GoToWebinar recordings. So with all of that, we're so excited, Dr. Arya, to have you here. Would like to ask you to turn on your webcam and join us on screen. And Dr. Vibhuti Arya, thank you so much for being with us. And I'm going to give you the floor so you can begin sharing some of the key information that you have for us today.
Thank you. I really appreciate being here. I think one of the things that I want to offer is certainly as a pharmacist, I went back to Hopkins to get a master's in public health with a focus on epidemiology, primarily because I wanted to just understand why data mattered so much and how to be able to determine what's good data versus bad data, and how do you determine pieces of information that are actually true versus kind of manipulating the truth and or not giving the whole truth. And so I think that where I come at this presentation is certainly with the professional background, but also with full disclosure that I had been on leave right before COVID hit and through this time, but very much in touch with what's happening with the New York City Health Department and my colleagues there, because I actually work in emergency management, emergency preparedness and management. And so it's been really interesting to kind of have this view as not only a public health professional, but also as a consumer of information, as a parent of a public school student, and in my work, primarily looking at the racial equity lens through all of our public health work that we do, and certainly in emergencies, how all of the inequities are magnified. So it's been interesting kind of taking a look at all of this, being in Brooklyn, New York, which is one of the epicenters of the epicenter where all of this is happening. And certainly, again, part of where our conversations and where our understanding of these data and why we look for these data, not only as a household, but as professional, comes from is, so my husband's also a physician at the Brooklyn Hospital Center, which again was one of the epicenters of the epicenters of the epicenters. And so it's been a really interesting way to understand how valuable the knowledge of epidemiology and why sort of taking data and understanding how they shape our narratives matter. And so, just to give you some background, when we think about epidemiologists, really is thinking about disease detection, right? So epidemiologists are sort of these disease detectives. And the way that we think about this are, we think about questions like, what are our exposures of interest? What are our outcomes of interest? And how do we create relationship between the two? Is there a relationship? Is it causal in nature? Is it correlated somehow? We look back at data, we look forward into time with data, and we essentially detect disease patterns. And the central to all of this is really the questions that we're trying to answer. It is really, really important to understand what are the questions that we're trying to answer, and how do we fundamentally utilize data in order to look at prevention and addressing public health and disparities. We'll go to the next slide. And here, we joke a little bit in Epi that it's basically the kind of like physics is looking for the truth out there in the universe. Epidemiology really is kind of searching for the truth, right? Do relationships exist where we think they may exist? Or is this kind of falsified? Are there other determining factors that are impacting what we think is a relationship, but truly may not exist, right? So we think about confounding factors. We think about what are the other variables that people are exposed to or that populations are exposed to that kind of alter the relationship between that exposure and the outcome. And so all of this really is important as we're thinking about the pandemic, certainly, because usually when we're getting data reported to us, it's typically during a later path of the disease, right? So we're not getting data as soon as people detect anything because it could be something else. And there are public health systems set up in place that actually can start determining if something out of the ordinary is happening. So certainly Seattle has a Seattle flu study. They have a sentinel surveillance system that was set up where they were able to kind of understand what's happening earlier on. And the point of understanding sort of what we call syndromic surveillance, where emergency department under normal circumstances, so pre-pandemic, are reporting what they're seeing in their emergency rooms, what hospitals are seeing, what primary care physician practices are seeing, for example. All of those things feed into understanding if there are certain outbreaks or phenomenal things that are happening that are appreciable using those data and understanding if something's actually happening. Certainly, we have talked about sort of underreporting, right? So in the beginning of this, you kind of had to assume that for every case that is known, there are multiple others that are unknown because there's underreporting, there's also, under testing. And so truly to understand the prevalence data, we have to do a little bit of detective work. And that's why the flattening the curve was so important, because essentially what it's saying is, look, we know that something's happening, we know people are getting impacted, but we don't truly know exactly who's impacted and to what severity yet. And so we need to make sure that we have the capability for responding to this. And so if you go to the next slide, this is what I want to talk about a little bit is how do we actually differentiate between good data sources, and how pharmacists can actually plug in to understand what's happening in their state, in their jurisdiction. So I love using New York State as a kind of case study. Certainly it's our work, but also shows the differences of when we look at data from a very high level versus granular, what we call granular data. So zooming in a little bit. This is New York State. And so I think a lot of people at this point know about Cuomo's daily briefings that were happening. And when we look at the picture of, and these links, by the way, in the handout should be live, and I tested them last night, and so they should work. Essentially, we can look at data tracking that's happening across states. But for example, New York City is a very different picture when it comes to understanding the density of the population, understanding access to care, and understanding pockets of the city that are less or more populated versus poverty levels versus disease burden. And so it's good to understand the bigger picture of what's happening in New York State. But on the next slide, you'll see that when we zoom in, and this tracker actually allows you to do that, everything grays out, but there's that thing on the bottom that really shows you specifically Kings County is Brooklyn, where I'm living and where we work, but really thinking about how do we hone in on those data that are impactful and understandable for us. The main thing that we need to think about when we're thinking about local data sources are, how long are they updated? How are they getting their resources? And also where the analyses are happening. So on the next slide, I'm going to give you an example. Throughout the presentation, I'm also going to point out some of the really interesting sources that pharmacists can go to. So this is, the source here is Johns Hopkins University, and it's interesting modeling that's happening with COVID-19. So these are kind of the growth rate cases, right? So in the US, this red sort of curve represents where we are at as a country, right? And so of course, all of us sitting in different parts of the country and internationally right now are wondering, well, where are we in our state? Where are we in our city? And so it's good to understand the larger national response. But if you go to the next slide, what we really want to think about is, how is our state doing? So New York has been able to flatten the curve, so to speak. And at this point in time, our growth rate is actually looking at cases are pretty much doubling at a rate of about every year, right? So at this point, if we continue to do what we do, whatever measures we've taken to control that curve, we've kind of flattened out this curve so that it's not steadily climbing. For example, in comparison on the next slide, when you look at a different place such as Florida, we can see that their case rate right now basically is doubling about on the average trajectory of every 2 weeks, which is very different and requires a very different response than, for example, the decision making with me or my neighbors or parents or children going outside to take a walk even, and where how all of that impacts our decisions, not only as individuals, but also as jurisdictions, to understand how we're essentially giving a response and guidance to citizens to understand how those responses go. If you go to the next slide, one of the things that we want to understand is, again, every time you're looking at the totality of data, we need to understand the credibility and totality of data, not just sort of a chic headline for your social media account. Data tells stories, right? And so one of the things that we've been hearing a lot is, how did this come about? It would be great to see. I'm a fan of data visualization. And so for me, when I look at things, it kind of paints a better picture. every virus has some sort of mutation rate, right? Every virus is going to have some variation as it moves through the population. And it's interesting, and you can go to nextstrain.org, where you can see throughout the world since the time that it was detected, how has COVID been translating and moving through the population of the world? And so it's a really beautiful way to understand the story behind how the virus has mutated, how the virus has changed, and how it moves through the population. This is more of a worldwide perspective. For those who may be interested in looking at a certain date range, looking at exactly what's happening throughout the world and and then you can look at the different responses and what that has meant. On the next slide, you'll see this is kind of my imagine if it were worse type of thing. So you might have heard, I think in the beginning, and certainly now certain folks are also talking about, in the grand scheme of things, we always want to find out, is this virus actually that bad? How does it compare with others? And how do we know that? And so certainly COVID-19 we consider it to be more infectious than, for example, seasonal flu. But when you look at this, the R naught that you might have heard of as a data point, it's actually not that bad, right? In terms of other kind of viruses that could be impacting our world right now. So the case fatality rate, essentially meaning when a person gets infected, how many more are they actually going to infect? The R naught, the reproduction of the virus, is actually not as bad as compared to some of the other things. And so as frustrating and challenging as it may be to be quarantined and take these what seem to be sometimes restrictive protective measures, it is so incredibly important to understand that if we can understand how to respond to this in a more communal and collective way, that we can actually set our systems up for better response in the future. Again, considering that the other viruses that could be causing pandemics actually could be a lot worse. And one of the ways that we have seen this be challenged sort of is, this, again, understanding of this collective risk versus an individual risk. So we are, in a society where I know that it's hard sometimes for folks to say, okay, well, I don't need to wear a mask because I'm okay. And the shift in the paradigm that we need to think about is more of a communal thinking, right? So it's not just my risk or my concern about going outside and wearing a mask or not wearing a mask, even if I'm fine, even if I have antibodies, even if I think I'm invincible and that I can't get the flu or COVID-19, or if I had it and I was asymptomatic somehow. The idea is that you could be still spreading it to others. And the lens of equity and kind of that consideration where it comes in is that, when we move to this phase of essential workers, mostly when we look at communities of color, when we look at communities who are not as privileged when it comes to income and benefits, and immigrant communities, these are the communities that largely make up who these essential workers are. So you're not only just healthcare workers, but also supportive care, orderly staff, looking at deliveries, food deliveries, etc. That we have to think about the totality of how we're putting others at risk, how our individual actions could be putting others at risk. And so each state, it's important to realize, doesn't live on its own and detached from other states, right? So it's in the best interest of everyone to take these measures really seriously and think about what we can do. And so if you go to the next slide, this is a really great resource that I love to share. That I love to share. It's called MedRx IV, and you can actually go to this, just Google it and click on it. It gives you a listing of all of the very current medical literature around COVID and what's happening around the world. And so I think this is a really fantastic resource for pharmacists to consider. And we're digging through, should I be reading this? Should I be reading that? Or, very specific recommendations on, for example, any new studies that may have come out around the world and how that may impact their populations. So I think that what I want to paint here is that data are complicated, and data are only really data until we analyze them and turn them into intelligence, right? So one of the very sort of important things that I realized from this pandemic that probably was a little bit surprising was the lack of an understanding around how to dig through what's actually true. And I guess in one way I wasn't that surprised, because I know that we're hungry for kind of quick tidbits. But on the other hand, really understanding that the old adage of lies, damn lies, and then there's statistics, and understanding how data can be manipulated and or snippets can be taken away without the realization that we have to understand the totality of those data. We have to understand the credibility, where the source is, when was it last updated. And so in very many ways, pharmacists are going to be called to really go back to their basic drug information skills, right? So even though we're asking drug info skills to be applied to an individual patient, we have to kind of take a step back and understand the totality of how epidemiology is shaping this presence of data that really inform us from a very different kind of lens in terms of the population, how we can be connected to the data sources locally, understand the national and global picture, but also understand how we can actually utilize those data to get a deeper understanding of our own communities who we serve. And so particularly in my line of work, we're constantly kind of forcing this through the lens of equity and understanding who are those vulnerable populations at risk, who are those vulnerable populations when we think about the risk categories and how this disease will impact them. For example, one of the things that we spend a lot of time talking about are what we call the crisis standards of care, right? So just the way when a code happens in a hospital, we don't have time to think through what the options are. We just have to understand the protocol right away and get that person and potentially save their life. In a similar manner, and the way that COVID has sort of magnified some of these inequities is that when clinicians who are called to do one-on-one patient care are at a heightened sense of anxiety and or responsibility and or stress, that a lot of their comments and their way that they make decisions could be coming from these implicit biases and our own sort of value and judgment systems, right? And so, for example, if you only have one ventilator and you need to care for a patient who you see as older or younger, poor or rich, etc., what are the things driving us to make that decision and say as a clinician, I'm going to prioritize one patient over the next? And so talking about this and realizing, again, looking at those data to show us who's more at risk or less at risk can really help us inform those decisions, coupled with our own understanding and unpacking of our biases can lead to better responses in a public health setting. And so having said all of that, I think that the key point that I would like to make is data are important to understand how we can actually have timely responses for prevention and for management and of any given disease, but certainly timely issues within a pandemic, for example. But data are only data until they turn into intelligence. And so one of the biggest things that we want to be mindful of and be very thoughtful is not misconstruing data to misrepresent anything that's not actually there. Again, that's why we think of EPI as sort of this search for truth. We want to make sure that those data, that we can understand and digest them and know their limitations, so we know how to apply it and not kind of create narratives where they're not happening, but really understand what truly the relationships are and how do we take those to then inform policy and programming and responses in a timely manner so that we're looking at the population at large. So I'm going to stop there and turn it back over to Michael.
Well, great. I want to also add on the next slide, you'll see that APhA, under the leadership of the Beauty and other members of APhA, have established a new public health special interest group. And the Beauty, we thank you and David, Steve, for doing that. And there are opportunities to get involved. So if pharmacists wanted to get involved in the public health SIG, how do they do that?
And I think one of the things that I forgot to reinforce is whether we think of public health in a traditional way or not, all pharmacists are impacting public health, whether they recognize and name it that way or not. And so one of the things that we felt very strongly was to have this group sort of be the convening body across APhA not only to promote and advance the role of pharmacists in public health, but also understand from each other internally and across to other associations how all of us are really impacting public health. And so we're really focused on the collective, and we're really focused on understanding data-driven approaches to improve care. For example, understanding access to pharmacists, right? Understanding how access to care happens and how pharmacists in the community can actually make a difference.
That's great. That's great. Well, what we want to do is engage our audience now. We've got a polling question for you this week, and we would like to find out how many of you have worked with the health department in your local community to respond to COVID-19. How many of you are working currently with your health department? We've heard some great stories at APhA about pharmacists who have been engaged with their local health departments, and we'd just like to get a sense from you. So just click on the response, yes, no, or not applicable to my practice. And if you just take just a moment to make a quick click on your screen, we'll be able to get some good data here, and we'll share that with you in just a moment. Okay, let's go ahead and put the results up. And it looks like about a third of you are, in fact, engaging with your public health department. And so I think probably could speak on behalf of the Beauty, but also APhA, in saying that we would strongly encourage you to do that. If you've not done it, reach out to your county health department or your local health department and find out what needs that they may have in the local community. Now, the Beauty, let's get back to some questions. By the way, audience, if you have questions, go ahead and type those into the question box. We'll take your questions as they come, but I've got some that were submitted in advance, and we're going to take those questions first. One of the things that is reality, and you touched on this a little bit during your presentation, the Beauty, is that there's a lot of data. I mean, it's almost data overload. And if pharmacists are, for example, on LinkedIn and Instagram and Facebook and Twitter, and they're getting just inundated, and then of course the cable news channels, data is being used as points, data points, and we're hearing this data and those data. How do pharmacists kind of, I guess, protect themselves from being swayed by the emotion that data elicits in all of us? I mean, we see a point of data, we have an emotional response, but pharmacists are scientists. So how do we ground ourselves to make sure that the emotion of data, a point of data, doesn't overtake us? What suggestions do you have?
So I will say, so I deliberately put those data visualization slides with the active links because I think that the credibility and the sourcing of the data matter. I think that there are certainly ways in which certainly data can be manipulated, but I think that there are a number of organizations doing a really great job tracking what actually is happening with COVID without interpreting it. And so I think that's part of the key is a lot of times, a lot of the data we are exposed to from social media are interpreted thoughts, right? They're interpretations of data. And I just like to push back, as I do with my students and colleagues, that we need to go back to the source and ask questions. And I think that as a practicing pharmacist, one of the things that you want to ask is, what data am I, like what answer or what question am I trying to answer? And then you know, hopefully where to go and get those data to answer that question. Because a lot of the data will matter on what you're trying to ask, right? And so I think that getting the facts from those organizations that I put in my slides, feel free to go and link on those. I think that there's a powerhouse of credible information, and I would just suggest to take one step further and not just take a social media post and kind of, you know, there's a lot of times you can kind of keep retweeting things that are maybe not the greatest thing to retweet and probably not the truest representation of data in the story that's actually happening. So dig deeper, find out what the source is, and go to a credible source. You know, I am not just saying this because I did my master's at Hopkins, but they know, their epi department knows what they're doing. They're, you know, the best for that reason. And so I think that it's very humbling to be appreciating what data you can actually you know, that's credible. So I think that go back to the source and understand the limitations of what those data are saying. So a lot of
Yeah.
times it can be a humbling experience understanding, well, the data show that this is happening. Does that mean the opposite is not happening, right? So I think that we just need to talk through that a little bit and not assume things and just question the assumptions of the data.
Yeah. So one of the most common comments that I think I hear people say, I hear pharmacists say this, I hear physicians say this, and consumers generally, is that our rate of COVID is increasing solely because we are increasing our number of tests that we're conducting. And so is the pandemic actually getting worse, or is this just a factor that we're testing more people? How would you respond to that as an epidemiology expert?
So I think that one of the things that I would parse out is that is more testing going to reveal more positive cases that are out there? Yes. So if you don't have enough testing, we definitely won't know who has COVID. However, it's not just a matter of because there's testing, incidence is not really true incidence. True cases are not really true, they're just there. I think in the beginning that was partly true, right? Because we weren't testing folks and we know this virus is here. You know, you have to assume it's here because if some people are getting it, a lot more people are getting it. Now that testing's well underway, yes, we're going to see more cases because you're detecting and looking for more cases. However, there's a very realness to, and again, having lived through this in New York, there's a real sense of understanding and kind of desperation when it comes to really helping people understand that true cases or new cases are not just because you're getting tested. It's actually because people are not taking the appropriate measures. So we've seen what social distancing and mask wearing and prohibiting indoor dining and all of that stuff can do, because that's how we were able to flatten the curve. And so I think that
Well,
it's really important.
I wanted to ask you a little bit more about that. Could you elaborate on some of those very important public health measures that you took in New York that you think were really critical in slowing the spread of COVID-19? You mentioned mask wearing and not dining in restaurants. With any other key takeaways that we could learn from the experience in New York about what really was successful, or what public health officials believe was successful?
Yeah, and I've been in touch with our colleagues, my colleagues at the health department as well. I mean, it's chaotic certainly, but this worked, right? So any indoor gatherings, people gathering, masks are certainly important, social distancing is certainly important, but I think the key to that indoor gathering is that we don't want people congregating in, especially in poorly ventilated areas where they can, just because they're there, give infections to each other without even knowing it. And I think those measures have certainly worked. And other states can learn from that in a proactive manner, not having to go through what we went through, so that your systems are not at capacity and going over capacity, where people are working and literally putting their lives on the line to help out patients. So these are things that all of us can do, and either enforcing it with yourself or your families, but certainly governments can also take charge in understanding how their populations can be impacted in a very proactive manner.
Okay, I'm going to ask the staff if we can unmute the line of Dr. John Rovers. Dr. Rovers, you've got a question, epi question for Beauty Today.
He's
John, your line
self-muted.
is unmuted.
Michael's coming across as self-muted.
Okay, you may need to unmute your line, John, on your end. Okay, I'll ask John's question for him. MERS and SARS had a higher R naught and were more lethal, but appeared to just burn, let me see if I can get the rest of the question here, just burn out. They didn't continue spreading. Any data on why this does not appear to be happening with SARS-CoV-2? So we can probably all remember when SARS and MERS happened, that they just, for some reason there was this acute spread. It really was in a few countries and then it just disappeared. And why is that not happening with this particular coronavirus?
Yeah, so I think in that slide that I had about the R naught, so you picked that. So MERS and SARS certainly have a higher fatality rate, for example. The difference is, for some reason, this coronavirus tends to spread more easily than, for example, SARS and MERS did. And so I think part of what we need to remember is that there are certain viruses, different viruses will have different properties, right? So for example, this virus is kind of wimpy, as my husband likes to say, right? But it needs to be respected. Like, you can wash your hands and you can get rid of the virus. But it needs to be respected, but it can be transferred very easily, right? And so the other thing is the mutations, pretty normal. Every virus has some sort of mutation, but for example, it's not like HIV. HIV has a pretty variable mutation that actually has a lot of consequence on its treatment and its the infection. And so it seems to be that that this virus in particular is just transmitted, that the spread of it is a lot easier than these other viruses. And so that's why, again, to reiterate the point, we have to think about, if we can contain this, we likely are better suited as a world to contain anything else, hopefully, that comes our way. Because if this virus were worse and easily transmittable, we would be in a lot of trouble right now.
So kind of a follow-up to that, we had a written question come in about, what percent of the population ultimately would either need to be testing positive or vaccinated and thus have immunity in order for us to see COVID-19 sort of stop or transmission stop? Is there a I guess what we would say a herd immunity number that you've seen in the literature, public health officials' estimates?
Usually when we think about it, we think about like 50 to 60%. 60% is a number that you'll see. And the idea is that more than half of the population either can stop sort of having this, severe sickness from it, right? So more than half of the population has some sort of immunity, either has it and can respond to it. And so generally we say, once you've achieved herd immunity, it usually tends to have a protective impact or protective effect on others who may not have been or who have yet to be exposed to the virus. So when it comes to the vaccination, that's one thing that I know people will kind of look at, right? But that also has sort of some, drawbacks in that people can come back, like their immunity. Vaccination does not mean full immunity all the time. And so the idea is that yes, we're probably waiting for the prevalence to reach at a certain point where people can start kind of easing up, but we don't know what that would look like exactly because we don't have a vaccine yet. We don't know how this virus will respond, but also we think about herd immunity and we say, okay, at least we should be able to achieve that. But whether or not that will mean that we don't need to worry about coronavirus or COVID-19 at all is something still kind of we're waiting to see.
Yeah. Okay, we have on the line a longtime public health pharmacist from Alabama, Charlie Thomas. Charlie, we're going to unmute your line, and we'd like for you to share your insights, having been a longtime public health pharmacist with the Alabama State Department of Public Health. Charlie,
you're self-muted.
If you can unmute your line on your end, Charlie, we'd love to hear your comments as a public health pharmacist yourself.
Oh, okay.
We can hear you. Great. Go ahead.
Hey, Michael, great. It's wonderful to be here in such a great program that actually series that y'all have put on, and I've really enjoyed them. My comment was that many health departments now employ pharmacists in various capacities, and that may be the easiest and quickest way for any community pharmacist to communicate with and interact with their State Department of Public Health. I was one of the first I was the first in Alabama, and there weren't really too many pharmacists involved directly employed by public health departments when I first started there, and I was there for 18 years. But pharmacists are involved in almost every aspect in public health where they're employed. And the comment is that you may want to reach out to your health department and discuss with their pharmacist that they have there in ways that you can become involved, not only directly in the health department itself, they may need some help, or in the community that they can help guide you through and help help you work with the health department to address any problems and things that they may want to do.
Yeah, those are great comments, Charlie, and your wisdom from working with the health department is very, very much appreciated. There is definitely a role for pharmacists to play here in public health, and we all know as pharmacists that during the early stages of the pandemic, when most things were shut down in our society, pharmacies were not shut down, and for many local communities, the only touch point in healthcare that was available were pharmacies, and that's still true in a lot of communities today. And so that essential connection with public health is so important. I'm going to ask Dan Zlott and Elisa Bernstein also to join us. They may or may not have video capability. If you do, you're welcome to come on. We've gotten some questions that are not about epidemiology as well, so we'll bounce around to a number of topics. Dan, I'm going to ask you the first question that has come in actually just before the webinar started. In the last few days, there's been some information circulating about proton pump inhibitors and possibly those increasing risk of COVID-19. I wonder, Dan, from a clinical perspective, can you speak to where this is coming from? Is this a rumor? Is this factual? Give us a little bit about the credibility of this information that's circulating right now.
Absolutely. Well, first off, good afternoon or good morning, everyone, depending on where you're joining us from. And as Michael said, you may have heard in the news about the potential link between PPI use and an increased risk of COVID-19 positivity. So where this is coming from, actually, Vibhuti mentioned a site earlier, MedRxiv, and that's the site where you can find the paper that's generated all this information. At this point, it's not been peer reviewed, so do take it with the appropriately sized grain of salt. But they did an internet survey, essentially, of more than 53,000 people. And of those 53,000 people, they found more than a little over 3,000 who were actually confirmed to have COVID-19. And in that population cohort, it looked like there was an unusually high element who were also taking PPIs. So the big question that follows that, of course, is should people stop taking their PPIs at this point? And kind of going back to the whole theme of Vibhuti's talk, understanding the data, it's really important to understand what this survey was. This is essentially non-randomized, non-controlled trial or survey data in this case. And so the information that comes out of that is really hypothesis generating, and it needs to be validated prospectively. So at this point, the general consensus is that there's no recommendation that patients stop taking their PPIs. So if you're getting that question from patients, the answer is no. There's no need to stop taking PPIs, and we need better data before we're able to assess whether or not there's a causative link. So again, Vibhuti touched on this nicely and set it up so well. Correlation, the fact that two things happen to be linked together does not equal causation. And so at this point, we have no evidence that there's a causative link between PPIs and increased COVID-19 infection rates.
Okay, all right. I am going to ask the staff to unmute the line of Mohammed Abbas. He's got a great question about the virus itself. Dr. Abbas, would you like to ask your question? We may be having some difficulties Yeah, we're having some difficulties today with muting, so I'm just going to ask the questions. I think through the rest of the program. The question he asked is it possible to get infected twice with COVID-19? So I think here what the question is there persistence of immunity? Once your body develops antibodies to COVID-19, is there persistence to immunity? And I'm wondering, both Vibhuti and Dan, both of you may have some insights on this that you'd like to share with us briefly. Dan, you want to go first from your perspectives?
Sure, I'll go ahead and start, and then Vibhuti can correct anything I said that's not accurate. How's that? So to date, there's really very little evidence one way or the other that demonstrates or confirms whether people can or cannot become reinfected. The best knowledge that I've seen are a couple of case reports that talk about reactivation, and I'm using that term specifically because that was the term that the authors used. And they had a couple of patients who tested positive. Patients at that point had no symptoms. Then the patients tested negative, and when I say tested positive or tested negative, this is by a PCR assay or a polymerase chain reaction assay, which is testing for viral genetic material, if you will. And so later on, after testing negative, the patients then tested positive again. So they were positive, they went to negative, and then were positive again. And in the second set where they were positive again, in both instances, the patients had actual, significant symptoms. And one of them, it was fairly severe. I think the patient ended up on a ventilator, and the other one, the patient required some oxygen support, but not necessarily mechanical ventilation. So that's an N of 2, and those are a couple of case reports. Now, was that reactivation? In other words, was the virus still present in the patient's system, but not at a level that was detectable, and then it got reactivated? Or was that reinfection, where the patient was infected, cleared the infection, and then got reinfected? And the answer is we really don't know, and there's a lot of unknowns there. Also lacking in that particular case report was any look at antibody levels to see if antibodies were present, and if so, what level were the antibodies present. So probably more questions than there are answers there. So that's a kind of a long-winded way to say we really don't know yet. It does seem that it's very clear that the overwhelming majority, more than 95, 99%, somewhere in that range, of patients who are exposed to COVID-19 will develop antibodies. The question is are those antibodies, they provide protection, and that's still the unknown. And also, how long do those antibodies last? So with that, I'll turn it over to Vibhuti to see if she's got anything to add.
Yeah, and that's great, Dan. I think that, again, it kind of goes back to the questions that you're asking, and the things you want to think about is, right, one, we actually, all of these antibody tests are also not created equal, and we don't know what all of them, if they're all very accurate either, right? So that's one thing to understand. The other thing is, just because you have antibodies, what does that mean in terms of the protection for immunity? Is it full? Is it partial? So that's another thing that we don't really know. And we also don't know how long that immunity lasts, even if you have full immunity. And so these are some of the things, that's why the whole herd immunity question is tricky, because there's the 60% is what we constantly see, but that assumes that everybody will not get the infection again. That assumes that everybody's fully protected, but there are people who get partially protected. So they may, for example, not have symptoms, but they could still be passing things along, right? So there's also this notion of partial protection. And so I think that's why part of this is tricky, is even if you have antibodies, it doesn't mean that you go out there and start partying, right? Because we don't know what that actually truly means. So all of that, to Dan's point, to summarize, that there's more unknowns that we actually have answers for.
Yeah, it's a complicated question and a complicated answer. It reminds me oftentimes, and I think pharmacists listening will recall this analogy. When measles vaccine first came out, we thought that you could take a single dose of measles vaccine and have lifelong protection, but it was actually almost 20 years later before we realized and recognized that you don't have lifelong immunity necessarily with a single dose. There's a portion of the population that needs a second dose in order to have lifelong immunity. community. Measles is a very different virus than COVID-19 virus, than the SARS-CoV virus. But we look at these experiences from the past to try to help us understand and predict what the future might be. As we as humans encounter these new viruses and these new experiences. The truth of the matter is we're not going to really know for several years how long persistence of immunity is going to last, because we're going to have to gain more experience and more time is going to have to pass. So we're going to be dealing with COVID-19 for a long time, whether that's dealing with it through active vaccination strategies or other mitigation strategies like masking more regularly and different practices and social distancing. These things will likely be with us for some time. Well, Vibhuti, I thank you for joining us. I'm going to ask now for Elisa Bernstein to join us. And Elisa, you have some new information to share with us from the government affairs team at APhA.
Yes, thank you. So can we go to the next slide, please? I want to first remind you all about APhA's 15 on COVID-19 series. These are short 15 to 20-minute videos that provide CPE. Our recent ones covered remdesivir, and then episode 21 covered telehealth, where Sandra Leal really nicely went through and explained the state of telehealth, and in 15 minutes, it's a really nice summary. So I highly encourage you to go back and look at these, and it's free CE. I also want to point you to APhA's COVID-19 practice resources. We have well over 20 at this point. We're continuously updating this webpage with new resources that are helpful for pharmacists. Most recently, we added one on vaccination basics, as well as telehealth and pharmacy practice. So go to our website, or if you have the slides open, you can click on this link to get you to the library of resources. On the next slide. So I'm just going to give you a brief update on some things that are happening on the regulatory and legislative front. We're hearing one thing that really impacts everything, a lot of what we're doing on the federal level, as well as on the state level, is a lot of the authorities that we're getting are tied to this declaration of a public health emergency. And under law, the public health emergency only lasts 90 days. And so HHS has to re-up this emergency and renew it every 90 days. And people were getting nervous that they weren't going to be renewing it, because once that gets renewed, some of these new authorities and flexibilities will go away. And just this week, we heard from HHS that they do plan to renew the public health emergency before it expires, so people know and have some forward future information. So there's a website you can go to keep track of that. I actually put this up here just so you know that the opioid crisis is also a continuing public health emergency that HHS continues to renew, because there are some additional flexibilities and authorities under that crisis that continues in place. So the next slide. There's a lot that was happening in the last week. If you are an APhA member, yesterday you got an email with our regulatory and legislative update, but I'm going to highlight a couple of the new activities and what APhA has been doing for pharmacists in the pharmacy community. One area that we just 2 days ago submitted comments to CMS on their interim final rule that provides COVID-19 flexibilities. And in the interim, in our comments, we asked for a number of things, and they're listed here on the slide. And one of the really key asks is to establish a clear pathway for pharmacist payment for testing and testing services. So for those of you who've been watching on our webinars and have reading some of the resources and other things that APHA has been putting out, we have been putting a lot of efforts along with working very closely with our pharmacy partners, association partners, in order to get very clear ways for pharmacists to get paid for testing and testing services. And this was one of the opportunities to provide CMS with some input there, because in the regulation, it created some hurdles and you had to jump over hurdles in order to get paid. And in some cases, we aren't even able to get paid for specimen collection. So we outlined some asks in that letter, and other areas are listed here. I'll just highlight that we did ask for CMS to expand the list of telehealth services that pharmacists can provide, and then also make those permanent as well. Next slide. Another area where the pharmacy community has been rallying together to use our strength in numbers in order to make change and advocate for change. And one area that we did advocate very strongly last week was sending a letter signed by 13 different pharmacy organizations asking HHS to authorize pharmacists to order and administer the COVID-19 immunization when it's available. And as you know, the administration authorized under the PrEP Act the ability of pharmacists to test across the country, and in a way that by doing so, it preempted and superseded any state or local laws or limitations or barriers. And so here in this letter, we're asking for a similar declaration and statement that pharmacists in all states across the country in all settings can administer, licensed pharmacists can administer immunization, and that it preempts state laws as well. So this was just submitted, and we're waiting to hear and get some action there from HHS. And finally, as we do in every week, if you go to the actioncenter.pharmacist.com, there's a really easy one-click way for you to send a letter to your legislators in order to tell Congress to help give pharmacists a provider status and the ability to get paid under Part B for testing and testing services. So I'll turn it back to you, Michael. Thank you.
Thank you, Elisa. That was a great update, and we appreciate the APHA staff and the hard work that you're putting in each and every week on behalf of our profession. I want to remind everyone that APHA has an interactive platform called Engage, where you can post questions and share experiences with fellow APHA members about COVID-19, the pandemic, and those things that you're encountering. And so we'd encourage you to take advantage of that. Now, we conducted a survey of individuals who've taken advantage of these webinars over the last 15 weeks or so. And one of the things that you told us is overwhelmingly that you really do enjoy having these webinars on a weekly basis, and you like the length of these webinars being at about an hour. So we would just like to say that we do plan to continue to conduct these webinars weekly for about an hour each week, covering the latest topics. So next week you can join us at the same time, same day, and same location. We'll post the pre-registration for that later today or tomorrow. It'll be Thursday, July the 16th at the same time that we have them normally. We also want to thank all of you for submitting topics that you would like to see us cover on future webinars. We're looking carefully at many of those topics and have gotten lots of great feedback and lots of great comments. And if you have further comments, please continue to submit those and send them in. And if for those of you who are not members of APHA, I would just like to encourage you to please go to pharmacists.com and take just a moment to join us. There's strength in numbers, and it's much better for us in Washington, D.C. To be able to say that we represent the entire profession, which we do as the American Pharmacists Association, but to have your support and membership really does mean a lot for our efforts in trying to get that done. So we just ask that you take a few moments to do that. Now, I'm going to take one moment of personal privilege, and while he's not listening live, he's going to hear this message on a recorded basis. Today is my father's 78th birthday, and I'd like to say happy birthday to David Hogue. So thanks for allowing me the personal privilege of saying happy birthday to my father. Thank you to all of you who have joined us this week, and thank you for all that you do in your local communities. God bless.